You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you've enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you. Hello, this is Richard Jacobs with the Future Tech and Future Tech Health podcast. I have Gabriele Barthlen, MD, PhD.
Yeah.
She's an ABMS board certified in both sleep medicine and neurology. And during her career, she directed sleep centers at prestigious places such as New York Hospital in Cornell and Mount Sinai in New York City, as well as the Freiburg and Munich universities in Germany. And she's published widely. She has 3 books out, 15 peer-reviewed articles, 33 abstracts, and she's been invited to speak at over 250 lectures. So, Gabriele, thank you for coming. How are you doing today?
I'm good, thank you.
Yeah, and it seems like you move around quite a bit. Where are you located right now?
Well, we have 5 offices in the Pacific. We have an office in Honolulu, in Pearl City, in Hilo, in Kona, and on Guam with a total of 17 beds. And I personally live in Kona, but I log into the different offices as well as travel on an almost monthly basis to each one of them.
So why did you move from New York and New York City to Hawaii? It's a good idea, but why?
Yes, that's exactly right. I did 23 years of academics and I loved New York, but after a while, when I got a little older, I said, okay, I want to live somewhere really nice. And I took up an offer in Hawaii, and then I opened my own sleep center, which is Sleep Center Hawaii and Guam Sleep Center, and we are the largest sleep centers in the Pacific at this point.
So the people that you see, are they different or very different from the people that you saw in New York?
Well, they all have mostly sleep apnea, which is they stop breathing at night, they snore loud, they're tired during the day. However, one of the differences is definitely personality. In New York, we had a lot of lawyers and business people, etc., etc. So I always had to be careful to cover my butt. Like I would dictate the report in front of them, so they knew, number one, it was dictated, and number two, that what I said is what they meant. Whereas here in Hawaii, people are so happy to even have a provider because this is more rural. So they come with gift baskets, and one of my colleagues actually got 2 goats as a present for being such a good doctor. So here they are extremely grateful. In New York, they're more demanding, like, doctor, what can you do for me? And here it's more like, what can I do for you?
Well, that's a good thing. So it sounds like it's better for you in every way. More relaxing.
Yes.
More beautiful, more appreciative.
And appreciative, exactly.
So do you work on advances in sleep apnea, or is it a condition that's easily treatable and it's well understood?
Okay. Well, we used to do a lot of research, not only on sleep apnea, but also on periodic movements in sleep and insomnia, etc. That was in my academic time. Now we just follow the most established treatment options. I mean, I do go to the American Academy of Sleep Medicine meetings every year and do a continued medical education on the side. But the apnea treatment has been pretty well established over like the last 20 years. There are some tweaks to the different treatment modalities, but it's pretty much 4 options that patients have with the sleep apnea, and they're all pretty established.
You said you used to study certain sleep disturbances. You said it pretty quickly. What are they? Or what were they?
Oh, one basically at Cornell and at Mount Sinai, we studied periodically movements in sleep. We studied insomnia. Um, we studied all kinds of other conditions. However, the sleep apnea treatment is very well established. So I'm not doing research. I'm doing clinical work. And the treatment options for people who stop breathing are number one, the Cpap machine, which is pretty well known. You even see at airports that people have to take out their Cpap machine. It's like a non-invasive ventilator. It works like a vacuum cleaner in reverse. It basically pushes out air, and it is connected to a hose, and the patient wears a mask that have become as small as almost like an oxygen tube under the nose, and that gives them the pressure support that they need because the airway collapses at night. That would be the gold treatment standard. There's also positional training when people only have apneas on their back because that's when the tongue falls back and they kind of choke. So there is positional training devices that put people on their side. There is definitely, we always recommend weight loss in somebody who is overweight or obese. And there are dental appliances that it's called mandibular advancement device, which brings the jaw forward and thus opens up the airway. There's also ear, nose, and throat surgery. For example, children who have large tonsils, you take out the tonsils and the adenoids, and that usually helps the apnea significantly or even cures it. So, depending on the history, the physical examination, the medications that people take, for example, if they take sedatives such as Valium or if they drink a lot of alcohol, that is discouraged by us since it relaxes the upper airway muscles even more and also it suppresses respiratory drive. So it's really, these are the main treatment options, but whatever is best for a specific patient can only be determined in a clinic visit.
Well, out of all these treatments, what are the predominant ones? Is CPAP used much more often than everything else?
Yes. The CPAP is the gold standard, which we always try first because it gives you 100% treatment result, which means patients may have 80 apneas an hour before, which means they stop breathing 80 times. They go like, and then there's a pause, and the pause is the disease, and then they go, and then they stop again. So if the relatives hear that, they usually make the diagnosis or the spouses. So the CPAP is always tried first. However, some people just cannot tolerate something on their face. You know, they have claustrophobia, for example. So for those people, we look at all the other treatment options. But CPAP is usually tried first. And in our clinic population, about 80% of patients actually can tolerate it. Once we exchange the mask, I mean, there's probably 40 different masks out there or interfaces because some of them are not even a mask. They're just a hose under the nose. It's called the dreamwear. And that is usually tolerated quite well.
Well, what are some things that you see help people get used to their CPAP? Is there training? Are certain masks better than others? What helps people get used to?
You can't really say which mask is better than the other because, especially here in Hawaii, we have Asian population and they have a very different nose from a Caucasian population. Or black people, they have wider nares. So it's really, you have to fit the mask like you fit a glove or like you fit a dress. And the better the fit, the better the results. So it's really individual. You can't just say, "Oh, we just like the Resmed mask, or we like the Philips Respironics Dreamwear, or the Resmed, or the Fisher Paykel." It depends on who needs the mask fit and how the individual likes it.
Are there any custom masks where they make a mold of your face and your features, and they make a custom one for you?
We are not using them. They have been some in Germany when I used to work in Germany, but not currently. I have not needed to make a custom mask.
Do you think something like that might be helpful?
There's so many masks out there that there is a fit for everyone. I mean, there's probably 40, 50, and maybe 60 or 70 different masks with different sizes, different cushions, different pillows. So there has not been a need to make a custom mask.
But there's got to be a way to do it where you don't have to go through all 40. How do you get someone very quickly honed in on the right mask? Are there certain questions you ask, or can you tell by looking at them?
Well, we have technicians who are well trained in mask fitting. There's also molds that we put on the patient's face, with cutouts. So we see if it's a wide or a medium or a small or whatever the patient needs. I mean, the technicians are usually pretty good in gauging what kind of mask a patient might need by looking and using their experience. However, there are the company sells the mask. When they sell us a bunch of masks, they always include a measuring device.
So the mask works whether you breathe through your mouth or your nose? It doesn't matter?
A very good question. There are full face masks that cover the nose and the mouth. And then there are nasal masks for people who are really only nose breathers. Most people actually will breathe through their nose most of the night. Some of them, though, are mouth and nose breathers. And those people we fit with a full face mask.
Okay. So a person will be suspected of sleep apnea, then they'll come to see you, then they'll do a sleep study, and they'll sleep in
Yes.
your sleep center?
Yes.
Okay. Because
Also,
your sleep centers are in the Pacific. Are they very beautiful sleep centers with palm trees and hammocks, or are they? I'm just teasing. They're probably
no.
very high tech, right?
Well, it's actually like a hotel room. We have mostly Murphy beds. So during the day we have clinic, which is we see the patients, and then at night the bed comes down, and the patient sleeps in the Murphy bed. They all full or queen size beds, and yes, the decoration is more Hawaiian style. We have wicker chairs, and we have a palm decor and pictures on the wall with turtles and dolphins. So the decor is definitely Hawaiian style. We have a Hawaiian pattern carpets, but and outside are palm trees. Yes, that is true, but it's not hammocks. Definitely not. And what I was going to say is there is also home sleep testing devices that have developed over the past few years. So for patients who cannot come to the hospital, to the sleep center, we would give them a home sleep testing device, which is only a screener because
device like.
Yeah, it's instead of 16 channels that we record in the sleep center, which also includes the brain waves to make sure that we actually record sleep and not wakefulness. The home sleep testing device only measures airflow, oxygen saturation, snoring, and body position. So it's a screener. If the home sleep test is negative, which means if it comes out normal, then we suspect the patient having sleep apnea, then maybe the spouse was wearing the machine, or they were awake all night, or they were only on their side during that night. So a screener, when it's positive, which means when it shows apnea, the patient has apnea. If it's negative, which means if it comes out no apnea, then we still want to evaluate the patient if our suspicion is high that they actually have sleep apnea.
Okay. Do you feel like the home kits work well, or is it better to just come in for a sleep study right away?
It is a better test, much more comprehensive, and we can also look for other sleep disorders that may cause, for example, a patient presents with he wakes up a lot at night. That may be due to many other sleep disorders. There's 84 sleep disorders, such as tooth grinding wakes people up, kicking their legs wakes people up, restless legs doesn't let them to go to sleep. There's narcolepsy. There's alpha wave intrusions. There's a lot of other sleep disorders that can cause poor sleep. So the way better test is a in-lab sleep study. However, the home sleep studies, we show the patients how to apply them at night. They take them home after they get like a short class, and we have about 5 to maybe 6 or 7% of failures, which means the it didn't record, or it didn't record right, or or the sensors fell off. But it's a fairly good screener.
Yeah, it must be hard when you're used to sleeping at home in your own bed, and then you have to go and sleep on a Murphy bed, and maybe you feel like
Uh,
you're being watched, and you may not be able to sleep at the normal hours you go to sleep, and same pillow
mhm,
and everything.
mhm.
What do people do?
It, yeah, that's actually a question that we get from almost every patient. How on earth am I going to sleep with all these electrodes on my head and a chest belt around my chest and an oximeter probe on my finger if I already don't sleep well at home? So what we recommend to those patients is they definitely should not take any naps on the day of the test. If they are afraid they may not sleep, they should sleep very little the night before, so they're really tired when they come into the sleep center. But even though patients initially are very suspicious, we rarely have a night that we have to repeat because we don't have enough total sleep time. They do fall asleep.
Hmm, okay. Do you know in your studies of sleep, how does sleep change if you haven't slept well the night before versus if you have? It's just a normal night's sleep for you. Has anyone studied
Uh-huh.
that?
Yeah. If you are sleep deprived, you usually go into more slow wave sleep, which is the deep sleep, and you may have more REM sleep on the recovery night. That would be like with one night or 2 nights of sleep deprivation. So they would have more slow wave sleep and more REM sleep. So,
Okay.
but we we usually want to see as much REM sleep as possible because it's in REM sleep that the apneas get worse. So actually, we want a lot of REM sleep
Why
to
does
see the apneas
apneas
at its
happen in
worst.
REM sleep more often?
They're more severe because in REM sleep we are paralyzed. All the muscles are paralyzed, and so the muscles in the throat that collapse during an apnea, they are even more collapsible because there is no muscle tone, and that's when the oxygen really drops to like 50% or even lower. If whereas in non-REM sleep they may just drop to 80%.
But that's still low. Normal
Oh
oxygen
yeah,
saturation is what, 95% is good or more.
95 to 100. Yes, right. Oh, we see very scary oxygen saturations, and unfortunately, the patients don't live too long. If they have untreated sleep apnea, our patient population is rarely over 60. They're usually between 25 and 45, and
Huh.
then they may have died already.
Really?
Yeah, because
Wow.
people get, when the brain doesn't get oxygen and the heart doesn't get enough oxygen, they get strokes, they get heart attacks, blood pressure shoots up, diabetes control gets worse, and they and weight gain continues.
Hmm.
So it's a pretty
So
deadly disease.
how long do you think it takes to affect someone to the point where they'll have a stroke or they'll die of some other condition?
Mm, well, it's difficult to study that, so I can only make a guess. Probably 10,
Yeah.
15 years of hypoxemia is probably enough to damage the tissue enough.
Hmm. So you said most of the patients are between 25 and 45?
Yeah, or 50.
Wow. That's pretty young starting at 25. That's
Well,
crazy. I
the
didn't
20,
realize it was so young.
right. Well, the 25-year-olds, I have to make a little disclaimer. Here in Hawaii and on Guam, we have a lot of military personnel. So about a
Hmm.
third of our patient population is military. And the military is very careful not to miss sleep apnea, especially in soldiers who operate dangerous machinery or who are pilots who really need to be awake and alert and oriented. So they send sleep apnea patients at the slightest suspicion. So that's why we get a lot of the young ones, because they want to make sure they catch it early. The military is very good in screening for any sleep disorder. They're also very good in touting that patients should exercise, they should eat well, and they should sleep 8 hours a night. I've seen those posters in the military hospitals, and I think that's great.
Yeah, that's good. Why do you think apnea happens to some people and not others?
Um, one of the conditions is basically the body habitus. If people have a small mandible, for example, they are prone to have sleep apnea. If they have a large tongue and a smallish mandible, they are prone to have sleep apnea. If they're obese, then the fat that accumulates in the neck kind of compresses the airway from the inside. They have sleep apnea. Um, when you get older, you're more likely to have sleep apnea because the tissue unfortunately becomes more lax when people age, like flabbier, and it's either anatomy or it is lifestyle. Like if people drink a lot, the alcohol relaxes the upper airway muscles and can definitely exacerbate sleep apnea. So there is a lot of predisposing factors and precipitating factors that you have to consider.
And what do you feel like you learned about apnea by working with it, for so long? Any unusual or interesting things you've learned, trends or knowledge?
Mm, Well, the most interesting thing that always still amazes me is how people change in terms of when they're treated. They come back and they say, you know what, I can work now. I don't fall asleep at the desk. I don't fall asleep driving. I can actually have sex with my spouse again because I have less erectile dysfunction. I'm happier. I mean, basically, whenever the brain does not get enough oxygen, including in the limbic system, which is our mood control and appetite control and sexual control, then people just are not doing well. So, what still amazes me is when they come in grumpy, kind of depressed looking, falling asleep in the waiting room. Spouse is unhappy. They have to sleep in a different room because they snore so loud. And then it seems to make a major difference in people's lives and the marital life after you treat the apnea. And that's actually why I like my job. And also, it's not just me. We also have physician assistants and APRN, which is Advanced Practice Registered Nurse. They actually see most of the clinic patients, and they love their job. They say, Dr. Barthlen, this is so nice. People don't go downhill, like in neurology, for example, which is my primary specialty. People usually get worse and they die eventually. ALS, multiple sclerosis, epilepsy, not many diseases get better. Whereas sleep apnea is almost like a panacea for many, many illnesses.
Well, that's great. That's excellent. What do you see as the future of treatment? Any new things coming that you think will make it even better?
Not that I know of. I mean, the mandibular advancement devices have become very slick now, so they are being used more. Um, Surgery is to be taken with a grain of salt. They used to take out the uvula a lot, but that doesn't really help much because the obstruction is usually at the base of the tongue. So the one trend I see is uh, people are also using the home sleep testing more. Like insurances want the home sleep test first because it's cheaper. However, from a medical standpoint, it's not the best solution. So yes, there are trends towards home sleep studies. There's trends more mandibular advancement devices, but that has actually been in the last few years, and I don't see any like new gadget on the horizon that maybe added to the therapeutic armamentary that we have to treat sleep apnea. So it's usually Cpap first, obviously associated, accompanied by weight loss, positional training, avoidance of sedatives at night, and then the second line would be mandibular advancement device, surgery, and that's usually efficient. If we go through all of these different treatment options, we can usually treat the patients.
Okay, very good. All right. Well, anything new coming in the next 6 to 12 months? Are you opening up any more locations? Are there any areas that are underserved that you want to work in?
Yeah, well, we are definitely in underserved area here in Hawaii. We were actually thinking maybe opening a lab in Salt Lake City or in Las Vegas. So we are toying with the idea.
Okay, well, very good. Well, Gabriele, thank you for coming. I really appreciate it, and I'm glad you found a better place to do the work, and your patients are very appreciative. That's good.
Good. Well, thank you so much for interviewing me, and I hope I can maybe save 1 or 2 lives by increasing awareness of how dangerous sleep apnea is and how much treatment can make people better. Aloha.
And the aloha. And the website to reach you or to find out more about the work. What's the website?
Yeah, sleepcenterhawaii.com. Like sleepcenterhawaii.com. That would be our website. And for Guam, it's guamsleepcenter.com. Or you can call 808-456-REST to reach us by phone.
All right, very good.
You're listening to the Future Tech Podcast with Richard Jacobs. Future technologies such as artificial intelligence, stem cells, 3D printing, gene editing, Bitcoin, blockchain, the microbiome, quantum computing, virtual reality, and exploring space are much closer than you might think. In fact, many early versions of these technologies are in play right now, and the companies that are using these technologies are the focus of this podcast. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a thorny medical problem. Remember, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you've enjoyed the podcast, please listen, subscribe, like, and tell your friends about it. Thank you.